water and bring your attention back up to the stage, and we'll introduce the next speaker. What happens when you give them a break?
Yeah, exactly. Totally understandable.
You folks ran the restaurant. Yeah, no, we are. Please return to your seats so we can start on time and give the next speaker his full time allotment. So, we are pleased to have Dr. Peter Wang here to talk with us about new advances in treating CF sinusitis. All right. Dr. Wang is a professor of otolaryngology, which for us nomenclature fans is ear, nose, and throat, at Stanford University School of Medicine, where he serves as chief of the division of rhinology. Dr. Wang's surgical practice is dedicated to treatment of sinonasal disorders in adults and children, and he has close ties to the Stanford CF Center. He has an active research interest in clinical outcomes of CF-related nasal and sinus problems. Please help me in welcoming Dr. Wang.
Good morning, everyone. Thank you so much for the opportunity to be here. It's really a privilege for me to be with you. And I am a sinus specialist, so that's what I dedicate my clinical practice to. And my CF patients are near and dear to me, so it's really nice to be able to come and meet with all of you today. I'm going to first comment a little bit about just why the sinuses are important in patients with CF. 100% of CF patients will have some objective evidence of sinus mucous membrane involvement. That doesn't mean that every patient will require sinus treatment. But because of the similarities of the upper respiratory tract and the lower respiratory tract, we can transfer a lot of our knowledge of respiratory disease in the lung to the sinus area in CF patients. And we know that not only in CF patients, but in other normal hosts, chronic sinusitis causes a significant impairment on quality of life. And so as longevity associated with CF is increasing, we see things like chronic sinusitis becoming more of an issue for patients on a day-to-day basis. And the sinuses, importantly, may serve as a reservoir for bacteria that may seed lower airway infections. So the very processes of these thickened secretions that we know to be part of the lower respiratory tract have an equal impact on the upper respiratory system. So let's talk a little bit about just what the anatomy is of the sinus. It's a little bit of a black box. It's not something that we think of often, but the sinuses are 4 paired air-filled cavities located between the eyes and the brain, and they have a functional aspect to them. They're lined with cilia. So cilia are these microscopic hair cells that sweep mucus along, and they have a big job because the sinuses make about 1/4 of mucus a day. So even in somebody without CF, you can imagine that that is a big task. And so if you then translate that to somebody who has thickened secretions, that can be an even more of a difficult task. And the openings through which we drain this mucus are very small. So the sinus openings range from 2 to 4 millimeters. And we don't really know why we have sinuses. I get that asked a lot, and I wish I knew the answer, except that it gave me a career. But apart from that, there are some theories. First of all, the sinuses serve to lighten the head. So if you look at a bird skull, it's one big sinus. So that's one theory. And then a second theory is that the sinuses serve as resonance chambers for the voice. So if you think about a guitar, the sound the guitar makes depends on the size of the air chamber. And certainly when we have a cold and we get filled up with secretions, people can tell because our voice sounds different. So the resonance is another aspect. And finally, the air spaces around the airspaces of the sinuses cushion the eyes and potentially the brain for impact against trauma. So if you were to get direct impact on your eye, let's say a baseball were to come to hit your eye, rather than the eye rupturing, the eyeball rupturing, you would actually absorb that impact by the fat surrounding the eye, and then the small bones of the eye socket would break into the sinus and therefore absorb the impact. So those are some theories. We will never know why, but we also do know that when the sinuses do not function well, it really causes significant problems for our patients. So the key to healthy sinuses is normal mucociliary clearance. And these are the cilia here. And you can see that in a normal patient, those cilia are well aligned, they're very orderly, and they sweep mucus in a very periodic fashion in a very directed way. So if you were to, and here's just a little bit of the anatomy, if you were to put a dot of ink on the bottom of the maxillary sinus, you could predictably follow that in somebody with normal mucociliary clearance, and it would actually drain against gravity. It would actually move up through here, out through that small opening that I was alluding to, and then back out the nose. And so we have, in this view, the maxillary sinus, which is in the cheek, the ethmoid sinus, which is between the eyes, and then the frontal sinus in the forehead. And looking along the side view, we have the fourth sinus, which is the sphenoid, which is the one that's literally in the middle of your head. It's the one that's furthest back. And what this map here is showing is the pathway of mucus that normally drains. So if I see a patient and I identify mucus here in the back of the nose, I can predictably follow that or predict where that came from and help to localize the source of the infection. So again, all of the lining of the nose and the sinuses have the cilia to it. And here's a little movie. I don't know if you can see it, maybe not with this light, but there's a periodic movement. They're like little whips that move in an organized fashion to sweep the mucus along. There are nerves that line the sinuses that also affect patients because of the distribution of the nerves, and they may be related to the pressure that people feel associated with sinus infections. The maxillary sinus is supplied by the infraorbital nerve, and that can present as cheek pressure or tooth pressure. And then the ethmoid sinus has an ethmoid nerve through here, and that's sort of the classic pressure right here between your eyes. And then there's a supraorbital nerve that innervates the frontal sinus, which would give forehead pressure. And then if somebody has an acute sphenoid sinus infection, that will most likely manifest as pressure either behind the eye or actually on the top of the head. And then importantly, there's the olfactory nerve. So patients who suffer from chronic sinusitis often have a diminished sense of smell. And the olfactory nerves line the top part of the nasal cavity. And so if you have swelling between the nostril and the top part of your nasal cavity, you can imagine that your sense of smell may be impaired. So this is a working definition of sinusitis for all comers, not just CF patients. This does apply to CF patients, though, as well. A disease process characterized by inflammation of the mucosa, the mucous membrane, and the underlying bone of the nasal cavity and paranasal sinuses. And this is an important definition because this is actually the first time in our specialty that we actually came up with a definition. So all outcomes research, clinical outcomes, before 1997 were dependent on the individual investigator's interpretation of what sinusitis was. And we actually now have diagnostic criteria that I'll show you. So the nasal and sinus lining is similar to the bronchial epithelium, as I mentioned. We call this now a unified airway concept. And the unified airway concept also translates to pathology as well. So pathology that affects the upper airway can also affect the lower airway. In asthmatics, we see this. So patients who have poorly controlled asthma may actually have sinus problems that are triggering the lower respiratory tract via inflammation of the upper respiratory tract. And similarly, in cystic fibrosis, we feel the same thing, that if somebody has significant problems in the sinuses, that may be affecting their susceptibility to lower respiratory exacerbations. So we see similar problems with abnormally thick mucus. And the cilia are structurally normal in CF patients, but the clearance of that mucus is impaired. Interestingly, there's been some research looking at heterozygous carriers of CFTR mutations, and it's thought to be that they might actually be at increased risk for chronic sinusitis as well. So sinusitis has inflammatory and infectious components to it. In the CF patient, in this vicious cycle, the problem really starts in terms of mucus stagnation. But you can enter this cycle anywhere, and that would lead to bacterial infection. So you can have some impairment of mucociliary clearance. So a lot of patients will have a cold, and the virus may actually temporarily impair the movement of the cilia, and that is why some people get a cold and that turns into a sinus infection. When you have mucociliary impairment, remember there's that cord of mucus that's trying to be cleared out every day. So if you have impairment of the mucociliary clearance, you'll have an environment that is prone to mucosal swelling, and that may be exacerbated by allergy or other environmental factors. Then the sinus will get obstructed because then there'll be mucus plugging, and that will propagate this cycle, causing more mucus stagnation. So how do we diagnose chronic sinusitis? Well, these are the official diagnostic criteria that we finally agreed upon in the late 90s. And there are major and minor criteria, and if you've ever had a sinus infection, you'll probably recognize some of these symptoms. So the major criteria are facial pain and pressure, nasal congestion, discolored nasal discharge, or loss of sense of smell. And the minor criteria are headache, bad breath, fatigue, cough, and dental pain. I would highlight fatigue because I think this is something that we don't normally associate with sinus infections, but it's actually now recognized to be a significant side effect or consequence of chronic sinus infections. And when we've looked at disabilities associated with chronic sinusitis with standardized quality of life questionnaires, fatigue is actually one of the top disabilities that's associated with chronic sinusitis. So in order to make a diagnosis of chronic sinusitis, you either need to have two major criteria or one major and two minor criteria. And this would then be supplemented by some objective evidence of sinusitis, either an endoscopy or a CT scan. So here's our setup at Stanford. We have a couple of different video monitors that we can look at, and we can capture images and archive them so that we can reference patients over time to see if there's been any changes. And then this is the endoscope with a high definition camera, and the patients can participate too by watching these video goggles. Now that we have Google Glass, I think I have more competition, but everybody wants to know if that's Google Glass. I said, no, these are actually like 8 years old, and no. But eventually. And so nasal endoscopy is a really important part of our exam. And so this is just a normal exam, just to kind of walk you through it. And you can see here's the scope moving into the nose, and it's just show you the normal landmarks. So this is the inferior turbinate at the front, and this is the midline. That's the septum. And the first pass on the nasal endoscopy is going to go towards the back. And these patients are anesthetized with topical anesthetic. So this is the back of the nose, and this is the eustachian tube, which connects to the middle ear. And that's why a lot of patients with chronic sinus problems have ear fullness because of swelling back in this area. Now we're going to move upwards and come back to the front. And then this view, remember I told you the sphenoid sinus is the one at the very back. So this allows us a view not into the sphenoid, but in the direction of the sphenoid sinus. This is the middle turbinate, and then the rest of the sinuses drain on the side of the middle turbinate in this area here called the middle meatus. So this is a normal exam, and I'll show you some examples of an abnormal exam. And first, just what are the factors that contribute to sinusitis? Well, genetic, of course, in CF, genetic. But structural is important as well. And structural issues that contribute to chronic sinusitis can often be remedied, and that's where surgery comes in. So somebody with abnormally narrow sinuses, or somebody that has an anatomic variation that narrows the sinus, or other things like septal deviation may affect the ability for those sinuses to drain. And then there's a host of immunologic and infectious issues as well. So we talked about viruses that can predispose to infections. Allergies can also, environmental issues. When we look at patients coming from industrialized areas, there's actually a much higher incidence of sinusitis. If you look at people coming from large cities like Mexico City, the incidence of sinusitis is actually higher. So environmental irritants, not necessarily mediated by allergy, can be important. And even things like hormonal changes. So there are hormonal changes, for example, associated with pregnancy that can cause nasal obstruction. And some of you in the audience, if you've had children and you've been through pregnancy, you may have had periods where your nose is really congested, and that is because of the hormonal influences. And then we talked about mucociliary function as well as being really key to maintaining sinus health. This is an example of a deviated septum. So the septum is the wall that runs down the middle of the nose. And you can see even just at the very front, it's already pushed over to the left side. And you can see here how that can narrow the drainage pathway of the sinuses. Here is a nasal polyp. So if we were to see this in a child, we would already be concerned about the possibility of CF because we do not expect to see polyps in children. So the presence of polyps in a child would be something where it would raise our concern for the possible diagnosis of CF. And this is just thick mucus draining out of the sinus. And when we see this, we will always want to culture that because that gives us more information about how to target therapy for patients. And you can see here too, this is just typical, very thick mucus associated with chronic sinusitis. So the other part of diagnosis, as I mentioned, is CT. We don't use plain films anymore. There really is not a role for plain films. And that's because CT really gives us so much more detail. And so CT is the study of choice for chronic sinusitis. Now, that being said, well, let me show you these scans first. You can see that because the CT will move through the head like a bread slicer, we can have all dimensions of that scan. We can reconstruct it in all different axes, so we can actually really study this, the sinus as well, and this is what we would use for surgical planning. So we'll always get a CT. If somebody comes in without a CT scan, there's no way that I would take that patient to surgery unless I had that information. This is a patient who has actually very small maxillary sinuses we sometimes see with CF. The opposite, which also can be a different variation, is an expanded maxillary sinus due to thickened secretions just not having a place to go and actually expanding out that sinus. So I did say that CT is the treatment of or diagnostic study of choice for sinusitis, but we actually do have concerns that we may be over-radiating our patients. If you look at the list of scans that patients get who are CF patients, there's just a host of studies just sequentially. And one of the potential solutions, and this is something we have at Stanford, is a cone beam CT. You can see this patient's getting one right here. You can see that she's sitting upright, and this is actually in one of our examination rooms. So this is a very innovative way of imaging the sinuses. The footprint of this is a little bit bigger than a telephone booth, and the scan takes about 40 seconds to do. The key here, though, is that the amount of radiation given for this scan is 80% less than a standard CT. And so if you have somebody who is getting multiple scans for multiple reasons, now this is something that I think is really valuable to consider to minimize the dose, especially in children where exposure to radiation at a young age can have a greater impact potentially on development of cancers later in life. So we have this in our office, and this is something that we now incorporate regularly, and we really feel like it's a nice asset for diagnosis. The other nice thing about it is in our office, so patients can just come to our office and get the scan, then walk down the hall, see us, and review their results. So what are the treatment targets in sinusitis? Well, I alluded to infection and inflammation both being important, and we don't really know which one begets the other. It's a little bit like a chicken and egg phenomenon. If you have infection, the bacteria can be pro-inflammatory in and of themselves. At the same time, when you have inflammation and you have thickening of the lining and thickening of the mucus, that serves as fertile ground for bacteria to replicate. So we really try to treat both. So we have anti-infective therapies and anti-inflammatory therapies. In terms of the anti-infective therapies, it's usually antibiotics. We do use oral antibiotics, but we also like to use topical antibiotics, especially in our patients who've had surgery. So we will always culture whenever possible, and here's an example of just aspirating thick mucus from a patient, and we do this sterilely so that we have a reliable result. And this way of collecting mucus is much more specific than simply swabbing the nose. And this is where your specialists can come in, because with the scopes that I showed you, we can actually go back to the source. We can harvest that mucus. We can isolate it in a sterile way and make sure that that actually represents what's in the sinus rather than just what's in the front of the nose, because we actually know that there are bacteria that just live in the front of the nose that don't necessarily represent what's going on in the sinuses. We do special lab testing for Burkholderia, Cepacia, and what we do find is that the organisms are quite similar to the lung. And actually there's a pretty high concordance of what you see in the sinus and what you see in the lung for any given patient. So I usually will, if somebody's coming in and they haven't been cultured in a while, I actually will go ahead and culture them even if they're not symptomatic, because I feel like that may be a useful indicator for what's also going on in the lung and what bacteria to expect in that sense. And it's quite remarkable when you look at the resistance profiles of these bacteria. When you see it in the sinus and you see it in the lung, almost certainly they're going to have a very, very similar resistance profile. So we're really talking about the same bacteria. So we will tend to treat patients with bad sinus disease with longer courses of antibiotic therapy. But we also are frustrated because that's a temporary solution. The relief is only temporary. Also, we know that the more we expose patients to oral antibiotics, this is going to drive antibiotic resistance. And that may eventually force us to run out of oral antibiotic choices. And that certainly has come up in some of our CF patients. There are also systemic side effects, as I'm sure you're aware, and cost. So we really like to use topical antibiotics whenever possible. And topical antibiotics are great if somebody's had surgery and the sinus cavities are open. They're less useful in somebody who hasn't had surgery before, because we've actually studied this, that the medication doesn't actually penetrate the sinuses, because the sinuses are kind of like a maze. So you actually can't get the antibiotic into the sinus unless you've actually surgically opened the sinus. And that's actually one of the reasons why we might consider surgery in a patient, to give them more options for drug delivery. And there are times when patients will have a horrible resistance profile to an isolated bacteria, and there are no oral antibiotic options left. And fortunately, we can actually formulate a lot of these intravenous antibiotics in a topical form. And we work with compounding pharmacies to develop these formulations. And so as a result, we have a wider range of therapies that are possible with topical therapy. We can achieve a higher level of concentration at the source of the infection. So that's another advantage of topical therapy, and potentially avoid systemic side effects. And this is just some of the antimicrobial options that have been described in the literature. And I've used any or all of these at some point. And we've even pursued some where we have to use a very obscure antibiotic when the resistances just direct us that way. But there's a lot more flexibility with topical therapy. So if we're going to give something topically, the next question is, how do we give it? And there are different ways to do that. You can put it in a spray bottle, you can put it in a rinse bottle, or you can nebulize it. And a lot of our CF patients are used to nebulizer therapy for their lower airway, so that's familiar. I think one of the things that I've always been interested in terms of my research, and I think is relevant clinically, is when we're using these medications, is it actually getting to the target? And so, for example, with the nebulizer, I saw a lot of patients who had these nebulizers, and they basically looked like the pulmonary nebulizers, except instead of just one hole, they had two. And when they first came out with these nebulized formulations, a lot of my patients were noticing that they were coughing a lot when they were using the nebulizer. So I was trying to figure out why that was, and we did some studies to try to understand that, and I'll show you those studies. But here's one study looking at distribution, and this study looked at blue dye that was delivered by these three methods: a saline spray, a bulb irrigation, or a nebulizer. And then with the nebulizer, the dye was actually deposited mostly at the front of the nose. It didn't get far back. And the saline spray and the bulb irrigation were actually more effective. And this is a study that we did where we actually used a little radioactive tracer in the nebulizer. And when we put the nebulizer in the nose, we actually saw a lot of it at the front, none of it in the sinuses, or minimal, and then a lot in the lung. And what we learned was that delivery of particles really depends on particle size. So if you have a pulmonary nebulizer, the particle size will be probably 2 to 4 microns, and that is designed to get that particle into the lung. So nebulized Toby, if you put it through the nebulizer, is going to get to the lung because it's 2 to 4 microns. But if you're trying to do use the same device to put it in the nose and sinuses, it's just going to bypass the sinuses and go to the lung. And that's why my patients were experiencing cough. And so there are some nebulizers now where they're trying to tune the size of the particle. But I found in my experience that irrigation is actually more predictable in terms of delivering the drug to the site. In addition, irrigation has a cleansing effect, and I think that that's very helpful for patients too. So that's what we use. If we look at the evidence for nebulized antibiotics, there's not a lot of evidence. This was a study that came out of Stanford before I arrived. And what they looked at, well, this is not a CF population, but they wanted to see what are the outcomes of nebulized therapy. And what they saw was that in these 42 patients, there was a longer infection-free period with nebulized antibiotics after completion of treatment compared to traditional therapies. But interestingly, the nebulized antibiotics also induced more rapid changes in bacterial flora. So what this is a reminder of is that we have to treat nebulized and topical antibiotics in the very same way that we treat oral. I mentioned to you, if we use a lot of oral antibiotics, we're concerned about driving resistance. Well, we can do the same with topical therapy as well. So we have to be careful about that. So our preference is the rinse bottle. This is the Neomed rinse. And you can see this unfortunate child, but he probably feels better after the rinse. So it's quite simple to use, and you can make your saline at home with this. And so we work with compounding pharmacies that will actually dispense shelf-stable antibiotic that can then be opened like a little pouch and then just placed into the rinse bottle along with the saline packet. And there is some evidence for irrigated antibiotics. This is also out of Stanford in this CF population. So FES is endoscopic sinus surgery, and this was patients with or without tobramycin irrigations. What they found was when they used the tobramycin irrigation, there was a significant reduction in the rate of revision surgery after 1 year. So caveats associated with topical antibiotics, certainly there's a potential for development of resistance, just like with oral. Occasionally you can have side effects. Even though we don't think that topical antibiotics are significantly absorbed, there are reports of patients who get dizziness with aminoglycosides or diarrhea. So it's certainly possible, although it's not common. And I would also caution you that the amount of data that we have for justifying topical therapy is still in evolution. So there's not a lot of published clinical data. When we use topical therapy, I do think irrigations appear to deliver drug more effectively to the sinuses than nebulizers do. Another target for us is biofilms. You may be aware that Pseudomonas and Staph aureus form these slime layers, and these biofilms are very complex ecosystems for bacteria to live in. They basically create these towers of this matrix that allows the bacteria to lay dormant at the base. And they create these channels with gradients in them. So all the nutrients and water will come down the gradient to the base. So they basically can just kick back and have food and drink served to them while they hide, really, from antibiotic therapy. And what will happen is the bacteria have something called quorum sensing, which means that once there's a certain density and it's no longer favorable for that population of bacteria to be in the same place, then they start to move, and the biofilm will release some of the bacteria to what we call planktonic form, which means that the bacteria then are released from the biofilm and they move to another area to set up shop. So you all have biofilms in your house. If you lift up your sink stopper and you scrape that slime, sorry to say, that's a biofilm. And a lot of our understanding about biofilm physiology actually has come from civil engineering because of holes on ships and pipes in water systems. They all can get biofilms. So biofilms are ubiquitous. That's just how bacteria live. But in the sinuses, it's a problem because it actually adds to this burden of trying to move this thick mucus along when the bacteria have formed this very organized, tenacious slime. And so that's a challenge for us when we're dealing with chronic sinusitis, especially in CF when we know that many of the major players do form biofilms. And so there has been an interest in how to eradicate biofilms from the sinuses. I will say that there's not really anything that's really proven, but there have been a lot of attempts, and we have some interest at Stanford also in tackling the biofilm issue. One way is just to use higher concentration of antimicrobials, so a higher concentration to penetrate that gradient. A second way is to actually try to disrupt the biofilm chemically. So detergents, or also known as surfactants, can be used. Xylitol is a naturally occurring sugar that may have anti-biofilm effects too, and we've done a clinical trial at Stanford looking at xylitol in non-CF chronic sinusitis patients. Or mechanical disruption. So there are power washers that are used to try to just flush that mucus out, and we have some interest in looking at the possibility of using ultrasound to break down biofilms. Just as you might imagine that the ultrasonic jewelry cleaners can break down, that can clean jewelry, there may be an application in the sinuses too. So there's limited evidence, as I said. This is one study that came out 5 years ago from the University of Pennsylvania, and they used baby shampoo in a concentration of 1%, so that means about 2 cc's of baby shampoo in one of the Neomed bottles. And they showed mild improvement in some patients. About half of the patients showed mild improvement. We are so desperate for biofilm therapies that this kind of took off, and a lot of people just started to try it and use it. And they actually tried to market a surfactant called Sinusurf. Unfortunately, after about 6 months, the FDA withdrew it because Sinusurf actually was associated with temporary smell loss. So patients actually developed issues with that, and most of them came back, but the product is no longer available. But a lot of people still try to use baby shampoo, and I'm not aware that there is a risk of smell loss with baby shampoo. But again, the literature is mixed. Another company tried to develop a different type of surfactant that was very effective against biofilms, but it not only removed the biofilm, it actually removed the cilia. And so the cilia grew back, but that was not something that they would release to the market. So we're really interested in how to break down biofilms, but we don't quite know how to do it yet. Anti-inflammatory therapies are also helpful. So for any patient with chronic sinusitis, be it CF or not, there's an inflammatory process that is propagating the disease state. And so we use topical steroids. We will use some oral steroids and allergy therapy. Topical anti-inflammatories can come in the form of sprays or irrigations, and when we use steroids for these, they're not significantly absorbed by the body, so they're safe for long-term use. They're not addictive, so that's always a concern for patients. The two concerns they have is this going to make me addicted to nasal spray? And it's not the decongestant spray, so this is actually safe for long-term use. The other concern is it going to affect my endocrine system because I'm constantly exposed to steroid? And the answer to that is no, that the topical forms just stay in the nose and they're not detectable in the bloodstream. In fact, you have to use it daily for maximal efficacy. Oral steroids are very helpful, but we like to use them sparingly because of their potential complications. So these are things that may be associated with steroids, insomnia, elevated blood sugars, irritability. I always warn the family when I'm prescribing prednisone because patients who take prednisone may just not feel themselves, and they may fly off the handle a little bit, or they may get moody, cry easily, all things that are good to inform the patient about before they take it. And then long-term, if somebody has long-term exposure to steroids, that can result in osteoporosis, cataract formation, and poor wound healing and easy bruising. So when do we consider surgery? Well, certainly if somebody is unresponsive to medication, has significant symptoms, if somebody has multi-resistant bacteria, or if somebody has declining pulmonary function or increasing lower airway exacerbations. I'll often hear from our pulmonary colleagues to see a patient in consultation to consider surgery. Well, does sinus surgery help? This is a recently published systematic review looking at 25 years of literature, and they had fairly rigorous criteria because there are many, many parameters that are typically studied in these studies. So only 24 articles met the inclusion criteria, but that did encompass 680 adult and pediatric CF patients. And what they found was that endoscopic sinus surgery does improve sinus symptoms in both adults and children up to 3 years in terms of the average follow-up. They could not demonstrate a benefit for lower airway outcomes, and this was primarily due to inconsistency in reporting. So there was no standardized way to measure post-sinus surgery pulmonary outcomes, so that there was nothing that they could compare to. So they could not actually show a benefit for lower airway. This study, though, did show that patients who have revision sinus surgery, so people who fail one surgery but go for a second, can have quality of life improvements with respect to their sinuses, also reduced number of hospitalizations for pulmonary exacerbations. And that's clinically statistically significant, although there was no improvement in their FEV1. What about sinus surgery before transplant? I practiced in Oregon before I came down to Stanford, and we had heard a lot about the Stanford protocol, which was to do sinus surgery before transplant. And so when I came down here, I traced back to try to understand the origins of that recommendation, and it was really a kind of an opinion paper, like a little 2-column opinion paper that really established this idea that patients should have sinus surgery before transplant to improve outcomes. So I questioned whether that was really necessary, and we developed a study to look at this. So we wanted to study the effects of pre-transplant sinus surgery in CF patients on bacterial recolonization of the lung grafts as well as survival. So what we did was we looked at the experience at Stanford. Between 1988 and 2005, most CF transplant patients had sinus surgery before their transplant. And then we compared those to other institutions, University of North Carolina and Pittsburgh, where it was routine not to. And we wanted to see if there was a difference in outcomes. So there were 87 patients, and what you see here is that at Stanford, the prevalence of the Pseudomonas colonization was really quite similar to the University of Pittsburgh group and the UNC group. And interestingly here, the time to Pseudomonas recolonization of the transplanted lung only gave about 3 extra days compared to the group that did not have pre-transplant sinus surgery. So we made the argument that if somebody is a candidate for lung transplant, they're probably not a great candidate for general anesthesia. And so it doesn't make sense to subject them to another anesthetic to have the sinus surgery if we can't show that it's actually changing outcomes. And there was no impact on survival either. So sinus surgery had no effect on time to recolonization. It also had no effect on the bacterial flora that we're seeing. It was still a high correlation between the bronchial lavage and the sinus aspirates, almost 100% correlation, and the survival rates were about the same. So despite sinus surgery prior to transplantation, recolonization of lung grafts commonly occurs, and at this time at Stanford, we do not mandate pre-transplant sinus surgery. So let's just talk a little bit about sinus surgery. What comes to mind when you hear the word sinus surgery? A host of images come to mind, I think, for my patients, unfortunately, including this, or this, and this. So I have a big task to try to introduce the idea that surgery might be helpful for a patient, and I like to just let the patients know that they need to figure out what their sources are for the information, because we have gotten better with our ability to manage patients with chronic sinusitis, and including patients with CF. So this is what a lot of people think about. You know, if they had an uncle who had sinus surgery in the early 80s, this is what we saw. So bruising, maybe cuts on your face, yards of packing in the nose that have to be pulled out like shoelaces. A week later, scraping the sinuses was the terminology that was used for sinus surgery. And then for the CF patients, catheters for irrigation and a long inpatient stay. So that's really not the case anymore. I do think there's less discomfort because our surgery is much more targeted. There's no bruising associated with surgery. We do almost all of our surgery through the nostrils only, so without incisions. There's no packing. We don't like to destroy the tissue. We don't scrape the tissue anymore. We preserve it. And we don't use irrigation catheters because we have these other options with the irrigation bottles now. And most sinus surgery, even in CF patients, is done as an outpatient, so home the same day. Surgery considered for failure of maximal medical therapy. As I mentioned, there's benefit to widening these drainage pathways not only for the function of the sinus, but also to improve delivery of topical therapy. And it used to be that a lot of patients would get admitted, CF patients would get admitted for a clean out, medical clean out before sinus surgery, and nowadays that's much less common. I'd say more than 90% of my patients are done simply as an outpatient. And actually, we have been studying, and we're currently submitting a manuscript on the predictive factors for outpatient surgery for CF patients. And interestingly, the pulmonary status actually does not relate at all to the predictive need for inpatient stay. It's actually just, it's pain. So if a patient has a higher tolerance for pain, then they're definitely going to have a higher chance for going home the same day. And it's the patients who need more intravenous medications for pain are the ones that will maybe need to stay one night. But it's rare for a patient even to stay beyond one night after sinus surgery. It's important for patients to understand that this is just an adjunct to the other therapies, and it's certainly not a cure. So this is a pre-op patient who has all of these little individual cells like a honeycomb, and then post-operatively, you can see they're hollowed out. So we still preserve the outer lining, but we remove all those little individual honeycombs that are trapping the mucus. So when we operate on a non-CF patient, we remember these mucus patterns guided by the mucociliary clearance, and we can actually make a hole at the very top of that sinus and expect that sinus to drain out. And we don't scrape the lining, but we can make a single hole, and we do know that that mucus is going to drain out through that hole. Now, in a patient with cystic fibrosis, this is an unrealistic expectation. Because the mucus is so thick, it's really not going to do that. And so I found myself revising a lot of patients who had this surgery with an assumption or a hope that the mucus would drain out, and actually wasn't enough. So we don't have to resort to scraping at this point. We can modify our endoscopic technique to make a big hole like this. And what this does is it creates a big window so that by gravity, the mucus will have a better chance of getting out. Also, it gives us a bigger window for irrigation, and it helps us in the office in terms of cleaning. So if we need to actually get a culture or we want to clean out that sinus, we have a much bigger opening into that sinus. And so the standard opening, this is looking in the right maxillary sinus, the right cheek. The standard opening might look like this, like an eggplant or a pear shape. And when we do this extended antrostomy, or what I call mega antrostomy, it's really bringing that all the way down to the bottom of the nose so that the rinse goes in and out rather than over the top and down. A lot of patients who have sinus surgery complain to me. They say, well, I like the irrigations, but then I go to work and I have to bend over and pick something off the floor, and then the irrigation comes out. And that's because in the maxillary sinus, it's like a bowl. And that's normal, and the sinus is draining out through the top. But one way to work around that and to really make sure that the irrigation gets out too is to lower that wall. So it's like taking part of the wall of the bowl down to the floor. So it can't hold the irrigation, but at the same time, the irrigation doesn't have to go over the top to get into that sinus. So we do believe that the irrigation gets in more effectively. And I'll skip this surgical part for you here, but I just want to show you this, which is that opening. So this is the normal opening, and this is the left maxillary sinus, but you can see the opening goes all the way down to the bottom of the nose. So you can imagine that somebody who's rinsing is going to have an easier time getting the irrigation in and out. And if you're delivering it with an antibiotic, there's a greater hope that that antibiotic will be delivered to where it needs to go. And so this is a patient with CF who had this mega antrostomy procedure as part of revision surgery. And you can see that, with this kind of thick, scabby, biofilmy mucus, but we can clean that in the office easily. We can also expect that irrigation is going to wash that out, and at her next visit, she looks like this and a little happier. Some of the new technologies that we have, computer navigation, is like a GPS system. So we can use a thin-cut CT scan to create a map of the patient's sinuses. And this is very helpful for complex anatomy. So it fits right into our surgical setup. And we get these type of images. So you get a little crosshair that moves within the sinus anatomy, and it helps us navigate around important structures like the brain, which is the top of the sinuses, and the eyes, which are the side. Nobody wants to be there. But patients with CF often have a lot of scarring, and it can be very difficult to negotiate the anatomy. And so having something like this navigation system can be very helpful. Just a little bit about our program. The Stanford Sinus Center is at part of the School of Medicine in the Department of Otolaryngology. And we have a real international team that I've been very fortunate to work with. There's probably about 6 or 7 different countries represented here in this group. And so not only we have a clinical team, but we also have a lot of international researchers coming from around the world to spend time with us. And some of the things that we're interested in, acid-base imbalances in the mucosa of cystic fibrosis. We're currently looking at genotype-phenotype correlations in the sinuses in CF and clinical outcomes of CF sinus surgery. We also have my partner, Jaker Nayak, is a stem cell biologist as well as a sinus surgeon. So he's actually looking at identifying stem cells in the nose, which hasn't been done before. And that may be a way to regenerate healthy tissue to replace diseased tissue. And then new technologies in terms of surgical technologies, such as this simulation. This is just the last thing I wanted to share with you, which is we have an interest in simulation, and the computer science department is a close collaborator with us to develop models to help train surgeons how to do surgery so they can practice maybe before they go to surgery, or how to teach residents how to do surgery. So you can see this is a dummy model here. And this is a very early iteration. This is not ready for prime time, but you can see that we can reconstruct a patient's 3D model based on their CT scan. And then with this simulated head, we can navigate through that. We can take that one step further by taking a patient like this, where we have a target, the green, which is a cyst, around very important other structures, the red, which is the carotid artery. So we want to open the green, and we don't want to open the red. Very basic, right? But easier said than done, because you can see how close they are, okay? So when we apply this 3D model to this, what we did was we sort of retrofitted this reconstruction to the actual surgery. We recorded the surgery, then we went backwards and tried to match the model so we could say, how close can we simulate the surgery? And so what you'll see here is now we enter, this is the back sinus, the sphenoid sinus, the one way at the very back. And you can see here the green and the red that we've mapped out, and this here represents this area here. So now you can see we're trying to match that up, and it's a pretty reasonable match. You can see the surface shadows, and that's the green target right there. Okay, and now we're simulating opening that on the simulation side, and this is the actual surgery where we actually were able to open that cyst. And you can see red is right here, which is right here. So if we can apply this type of technology to real intraoperative navigation, we could really give a patient a greater margin of safety for complex lesions like this. So that's the future. But someday that'll maybe come to a operating room near you. I want to thank you very much for your attention. It's been a pleasure to be with you this morning.
We're going to open it up for questions. Again, if those folks would like to line up there by the microphone stand, we'll bring the microphone right out to you. Thank you very much for Dr. Wang for sharing the latest treatments. Repeat after me, sinusitis, sinusitis. An hour ago I thought it was sinusitis, but it's sinusitis. So please limit your questions to one person, and please avoid any questions which are specific to your child, which is tough for me because our son, Joe, was in the hospital, had sinus surgery this June. So I'll talk to you offline.
Yes.
I have a question about sinusitis and the openings and the drainage to the lungs. We've been through 9 sinus surgeries, and so it's been brought up several times by the pulmonology. Is this really the best choice? Because if we're opening up so it can drain out, you're just opening it up to easier drainage to the lungs. Is that, where do you stand on that?
Yeah, that's a fair question. I think it's hard to know. It's hard. I haven't known a patient to become worse based on sinus surgery. It could just be that in that patient there was more in your family member that there's more disease to begin with, so they're just going to do worse after sinus surgery. There's no evidence that opening the sinus actually makes anybody more susceptible to more infections or more allergies. That's another concern. Now there's more airflow, am I going to have more allergy problems? But if you think about not having the access to that sinus, you have fewer options to try to treat. So I think unfortunately, there's a wide spectrum of severity, and that is one of the things that we are interested in. We're trying to correlate genotype and phenotype because we have some CF patients that have noses that look like normal patients after surgery. I mean, they don't look like they have CF. And we have other patients where it's just a constant battle. So it may actually represent more of the underlying phenotype more than the fact that the surgery did something to change the adaptability of that sinus. Yeah.
So I have 2 clarifications. So
Yes.
in fact, I think you just said, so there is no correlation between once you open up the sinuses and then the introduction of bacteria or allergens. You're saying that
Right. I mean,
they've
I think it's
studied that
theoretical,
and
but nobody's proven that.
Oh, so nobody's studied it yet?
No, but if you look at just in terms of outcomes, the many more people get better after sinus surgery than get worse.
Right, okay.
So.
Okay. And then the other thing I wanted to clarify, you said during your talk was it the heterogeneous people with CF
CFTR.
have a higher risk of sinusitis?
Yeah, so if you only have one copy of the mutation,
Okay.
so you're not clinically manifesting cystic fibrosis, some researchers have been interested to see whether having only one defective copy would impair sinuses. And there's some suggestion that even having one impaired copy can change your susceptibility to sinus problems. And
I see.
therefore, if you have CF and you have 2 defective copies, you're clearly going to have sinus problems.
Okay, but not if you're heterozygous for like Delta F508. That doesn't necessarily mean that you're
It doesn't mean that it doesn't mean that you're going to have sinus problems. It's just a study that I wanted to highlight to show the relationship of CFTR abnormalities to chronic sinus disease.
carriers. Okay,
Yeah.
thank you so much.
Sure.
So my wife, God bless her, she used tobramycin and lost her sense of smell.
Mm-hmm.
And now she has a hypersense of smell, which is dysosmia.
Mm-hmm.
So we can't have fish in our house. Is there anything you can do? Do you know anything that would help her so that I can have salmon?
Yeah. That's a tough one. I mean, the sense of smell, is clearly related to sinus disease, and yet it's very poorly studied. All of my patients has a problem with sense of smell. I try to encourage them by at least telling them that the Nobel Prize in Medicine was awarded for olfaction several years ago to heighten the awareness of the issue. But usually in somebody with chronic sinusitis, the changes in the olfactory function are related to the inflammatory condition of the nose. So in my practice, we would be more aggressive with trying to control the inflammation with steroid irrigations, perhaps oral steroids if necessary, and then also controlling the infection because that propagates the inflammation.
I'm thinking hypnosis.
So that wraps up the time for questions for this speaker. He will be here Sunday.
Actually, I won't be able to be here
Oh, you
So,
won't be here
yeah,
Sunday?
I'm happy to take questions now, though. I'll just
Okay.
be here at the front. And
Okay,
anybody,
great.
you're
So
welcome
he'll
to
take
come up.
questions one-on-one on the front here. So once again, thank Dr. Wang for sharing the latest treatments for sinusitis. We invite you once again to stretch and take a moment, get up, and we're going to have our third speaker and final